Let's discuss a very nice case. A 28-year-old female presented with chronic lower abdominal pain and dyspareunia. The history is the pain is long-standing, dull aching in nature, and gradually progressive. Now, as a radiologist or as a clinician, our differentials will be endometriosis, pelvic inflammatory disease. Actually, this is a quite broad uh, differential diagnosis. It can be endometriosis, it can be pelvic inflammatory disease, can be adenomyosis, and the imaging plays a crucial role to differentiate the endometriosis and pelvic inflammatory disease. Now I did the ultrasonography. This is actually the transabdominal image, and the uterus is quite lengthy. It is approximately 11 centimeter, 10.8 centimeter in the length and 2.7 centimeter in the epidiameter. And see here, there is a chink of fluid. There is a little amount of fluid in the pouch of Douglas. And this amount of fluid actually considered normal in the female patient. Sometimes it can see in the uh, young children also. Now see the posterior wall and the fat. The posterior wall we can demarcate, we can draw a line along the posterior wall of the uterus, and there is no hedginess, nothing. And see the uterine myometrium also very homogeneous. Other than this part, there is some cystic spaces in there. And this is the transverse part of the body of the uterus. And see there is also some anechoic area or cystic area in the uterine myometrium and at the parametrium also. And see, this is the ovary. So right ovary is quite normal, and there is a small follicle, and there is also a small follicle in the left ovary, and this is the dominant follicle in the left ovary. And this is a transvaginal image of the cervix, and see the dimension. The AP diameter of the cervix is approximately 2 centimeter, and the both cervical leaves are homogeneous. The endocervix is also normal. There is no fluid. There is minimal fluid in the pouch of Douglas. And there is a Cripsey line. There is a well demarcated line we can draw. This is the posterior border of the uterus and cervix. And see, this is the color image. This is the, we put the Doppler and there is no increased vascularity. In the cervix, the endocervix is normal, the cervical lips are normal. And see, this is the parametrium. And we just put the color in the parametrium. See, there is dilated tortuous vessels in the right parametrium. And also, see, actually, see this one, the B mode image, there is anechoic space and anechoic tubular space, the cystic space in the myometrium. In the most of the myometrium, there is tubular anechoic structure. And the endometrium and myometrium junction is well demarcated. This is, there is no, we can distinct the endometrium and the myometrium, and there is no hyperechoic focus in the myometrium, and there is no cystic spaces at the endomyometrial junction. And see, this is the left parametrium. There is also multiple tortuous vessels, and this is the uterus. We put the color, and this tubular anechoic space actually filled with the color, and this is actually dilated veins, dilated vessels. And check this cine image. This is the parametrium. There is anechoic channels, anechoic structure in the parametrium, and see in the myometrium there is also anechoic tubular structure in the myometrium of the uterus. And see the endometrium myometrial junction. This is very well demarcated. The uterine outline also very well demarcated, cryptsy, and this is the parametrium also. There is dilated anechoic tubular structure. See this one. And this is the color image. This is the Doppler image of the uterus. And see, the Doppler image shows this channel. Actually, this is actually a vascular channel in the parametrium and in the myometrium of the uterus. So, putting all these findings together, the diagnosis points towards pelvic congestion syndrome. What is the pathophysiology? Actually, the pathophysiology of this condition is due to ovarian vein incompetence, leading to venous reflux and stasis in the pelvic veins. Over time, these dilated veins become a source of chronic pain. Clinically, this patient often complain of pain that worsen on the prolonged standing towards end of the day, and sometimes even postcoital pain. So, as radiologist, it is very important to recognize these subtle but critical imaging features, because this is a treatable condition. With correct diagnosis, patients can benefit from minimally invasive procedure like ovarian vein embolization, which can significantly improve the symptoms. So next time, when a young female patient presented with a uh, chronic pelvic pain and dyspareunia, don't miss pelvic congestion syndrome in your differentials, because sometimes the
Let's
diagnosis
discuss a
is
very
not
nice
rare,
case.
it is just under
A
recognized.
28-year-old female presented with
Chronic lower abdominal pain and dyspareunia. The history is the pain is long standing, dull aching in nature, and